Good evening. Welcome CP Research Network MyCP webinar series. My name is Paul Gross. I'll be your host for the series. I'm really excited to have Lisa join us to talk about the work they're doing within the network to expand the range of where we can do diagnosis. I'm getting a message that my internet's unstable, which is a concern and a problem I've been having. So please send a chat message or whatnot if you're feeling like you're losing me, and I may shift gears. Pardon me, I'm just trying to deal with this, my challenged internet connection. Quick agenda for the evening is to do the introduction to the CP Research Network. A number of you that join us for most of our webinars will have heard most of this, but we'll have a few updated points that you might be interested in, and then we'll dive into the presentation from Drs. Letzkus and Vesoulis. And then we'll go to an open Q&A. So the mission of the CP Research Network is to optimize the lifelong health and wellness of people with CP and their families through high quality research, through education, and through community programs. Since our founding in 2015, we've made tremendous progress on our kind of core pillars of education, research, and wellness. One of our initial focuses were on the community, and we launched the CP Toolkit in 2015, and we've served more than 5,100 copies of that up either online or in print to members of the community. And then we went on to do well-being guides and then translate the toolkit into Spanish and Portuguese in 2017. And then in 2020, we launched MyCP, which one of the things it does is enables personalization of web information, the rich information we have on our website. On the research front, we launched our clinical registry, which was really much of the core, along with that educational focus that we were founded on, was to create a clinical registry to engender more research. It was launched in March of 2016 and now has more than 8,000 patients in it. And then we have a community registry. So the clinical registry collects data when people come to the hospital, and the community registry is something people can participate in through MyCP. And that was launched in March of 2019 and now has over 2,200 people in it. We're patient-centered from the outset. We did a research CP, which is a patient-centered research agenda, which was published in 2018 and guides much of our work. Gone on to get some significant funding milestones with the National Institutes of Health through our genetics study. And then we recently partnered with the largest private funder of CPARF or CPI Research Foundation. We have applying for money or in the execution phases. And we also have 4 quality improvement initiatives, which are really aimed at changing the system of care to improve outcomes much more quickly. We've had 9 publications, although I say that we've had our 10th accepted. We've had over 39 academic presentations, and we have 5 manual. We partner with the National Center for Health, Physical Activity, and Disability to offer a program to the CP community that focuses on mindfulness, exercise, and nutrition to optimize resilience. So the network is a 501c3 nonprofit. One of the things we fund is a data coordinating center. So those registries are databases, and they're stored securely at the University of Pittsburgh, where we have both our clinical and community registries. The 501c3 has these education and well-being programs, and this and MyCP, this free personalized web portal, which really gives you access to the community registry, the opportunity to discuss priorities in research and engage with clinician researchers, personalized web services, and access to our wellness programs. And you can, if you're not a member, I would encourage you to sign up at mycp.org. To give you an idea about what is in registries, so we use the gross motor function classification system as a key metric about people with CP. And what you see, this is from a snapshot back in November 2021. I just haven't gotten an updated graph. with our new larger registry. You see the distribution of people based on GMFCS, or gross motor function classification system, is how people move through the community. How do they ambulate, or do they move with a wheelchair? And then if you look at the age distribution, you'll see that it's more heavily pediatric, because we have a lot of pediatric centers, but more than 22% of the people engaged in our registry are adults. The community registry, on the other hand, represents a bias of who is on the internet and who is active and finds our work. And you see it much more heavily leans towards people that are GMFCS level 2, people who can ambulate independently. But when you look at the age, it leans much more into the adult population, because adults are very active in advocating for themselves and participating in research. So those are the programs of the network. The network is spread across the United States and Canada. It's a 30-center learning health network. The green pins represent sites that are enrolling patients in the network. Yellow pins are sites that are preparing the technology. Red pins are sites working on the compliance and regulatory aspects. And the blue pins are sites that have raised their hand and said, we're interested in joining, but we don't have the people power or the means at this stage. And so that's actually a growing list of sites interested in participating in the network. So I am very excited to be able to turn it over to tonight's speakers. Dr. Lisa Letzkus is a nurse practitioner and nurse scientist and an associate professor in the Division of Developmental Pediatrics at UVA, or University of Virginia. And she is a co-principal investigator on this study that we're going to talk about. And Dr. Zach Vesoulis is an assistant professor in the Division of Newborn Medicine in the Department of Pediatrics at Washington University, or WashU. And he is a co-PI on this study, as well as co-director of the NeuroNICU program at St. Louis Children's Hospital. And with that, I turn it over to our gifted speakers to talk about early detection.
Thank you guys so much for having Zach and I today. We're going to give you some background and an overview of our project.
I'm not hearing, Lisa, I'm not hearing you. If you're speaking, that could be a problem I have.
Can other people hear me?
I can hear you.
I can hear you, Lisa.
Okay, I was like, oh my gosh.
Yes, no problem.
Made me start sweating. Okay, so thank you so much. We're going to give you an overview and some background of our project. And we currently have a application under review for CPRF that we're hopefully going to find out soon. And our study title is Multi-Center Early Diagnosis of Cerebral Palsy, the MSCP study. Can't take credit for that, but thank you, Christy, for coming up with the nice acronym. Okay, so times are changing. I've actually been a nurse practitioner now for 15 years. I can't believe it. And really in 2017, this publication that came out with Dr. Iona Novak and colleagues really changed the landscape of diagnosis of cerebral palsy. Cerebral palsy had a median age in the United States of 24 months or 2 years of age, was the average diagnosis. And in surrounding countries, that is even higher. Did someone have a question? Okay. And if in some less severe cases, it's also higher in the United States. There was also this philosophy of kind of wait and see, let's see how the child or individual progresses. And there was just always kind of this delay in diagnosis. And we relied a lot on neuroimaging to make that diagnosis. But in 2017, like I said, Iona Novak and colleagues really came together and put forth these international guidelines for identification, intervention, and treatment of cerebral palsy at a very young age. So I don't know if you guys can see this, but we'll walk through this algorithm, but really, you know, understanding risk factors of cerebral palsy, which can be babies born preterm, babies that have undergone some type of hypoxic event or encephalopathy at birth. But then there's other babies that we're just not really sure of. There may be difficulties growing in utero, born with different congenital differences, or they may come to clinic and their newborn course may have been unremarkable, but parents just have a concern and they note differences in their movements that may prompt an evaluation. So now we have the tools, even as early as being in the NICU, to start evaluating these babies and kind of determining risks for cerebral palsy. And also just really want to highlight that Natalie Maitre and colleagues published a multi-center quality improvement initiative that really looked at implementation of this algorithm in the United States at several academic centers, and was shown that they were able to reduce the diagnosis down to less than 12 months, so a little over 9 months of age, using this algorithm, which is great. So these are a list of kind of the early detection tools that are summarized in this guideline. The first one is called the General Movement Assessment. There's many benefits to this test. It is non-invasive. It's also inexpensive to administer. However, it does take training, that can be costly. It can cost for basic training around $2,000 and upwards for the advanced training. So there is some cost on the front end to get people trained at your institution, but it's non-invasive, does not hurt the baby. You take a video for about 3 to 5 minutes, and then individuals that are trained on this exam are later able to score the video and determine risk of cerebral palsy. This can be done shortly after birth, as well as up to 4 months of age-corrected gestation. Then there's the Hammersmith Infant Neurological Exam, or the HINE, or some people call it HINE. And this is a standardized neurological assessment that is also performed by individuals that are trained. It does take a 1-day training course to learn how to perform and administer the test. To administer the test, it could take anywhere from 5 to 10 minutes. And this evaluates tone and strength in muscles. The difference between the General Movement Assessment, which is a qualitative exam, is that the Hammersmith Infant Neurological Exam is a quantitative exam. So it gives you a number that you can kind of trend over time. You can start performing this exam when the baby is 2 months corrected up to 24 months of age. Then there is the test of infant motor performance, or the TIMP. This is a little longer test, also takes some training to learn how to do it. It's a quantitative test and takes about 30 minutes to administer, and it includes 42 items. It's also non-invasive and looks at spontaneous infant activity as well as some elicited movements and seeing how the baby responds. And then there's the gold standard that has been around for forever, and that is the MRI. And it is expensive. It does require sedation in some cases, especially when the child has been discharged from an intensive care unit and is more wiggly, because it takes about 45 minutes to get a brain MRI, and we need the child to be very still. There are some research scoring methods that exist, but mostly when an MRI is obtained, it's subjectively read or evaluated by a neuroradiologist, and they're really looking for abnormalities in or differences in how the brain is growing or targeted areas of injury. So how do we evaluate these tools? How did they choose these tools to promote for the early detection guidelines? And these are some terminologies just to familiarize everyone with, related to sensitivity. And that's the probability of a positive test result in a patient that actually has the condition. So can this test determine that a child has cerebral palsy. That would be the sensitivity. The specificity is the probability of a negative test in a patient that truly does not have the condition. So can the test determine if a child does not have cerebral palsy and is accurate with that? There's also something called the area under the curve that you could see when you read some of these articles, and that's also referred to as abbreviation called the AUC. And that's a predictive model that takes into account the actual true positives and negatives, also the false positives and negatives. And the range that you get usually is 0 to 1, and the closer to 1, the better the test. There's also accuracy, so measuring of how close a prediction is to the true value, and then precision, which is the measurement of how consistent a prediction is for the same patient from test to test. So why does this matter? The importance of early intervention. We want to make sure that we're doing tests that are not giving us false results. So the pathway really outlines 2 different age groups. So infants less than 5 months of age and infants greater than 5 months of age. And so specifically looking at the pathway of the newborn and detecting risk factors of cerebral palsy, we're really looking at the general movement assessment. And in the NICU, there's a stage called writhing. And then during the outpatient, when the baby usually goes home around 3 to 4 months of age, they transition into this movement phase called fidgeting. I know it's a tongue twister, but again, this absent fidgety pattern that providers are learned to recognize on the GMA and in combination with a brain MRI can accurately predict the diagnosis of cerebral palsy 95% of the time. The test of infant motor performance predicts CP 61 to 90% of the time. When you actually put all of these tests together in a pooled performance and doing them not individually, but in combination, we have a sensitivity of almost 98% and then a specificity of 99%, which is great. And why does this matter? Because early diagnosis can lead to earlier intervention. And families want to know how they can help their babies and young children. And it's not just related to the motor domain, even though that's something we focus a lot with related to cerebral palsy. But we also have heard that they're interested in interventions related to cognition, communication, eating and drinking, services for vision, assistance with sleep, management of tone, differences in the musculoskeletal, their mental health, and their overall parenting. I just want to highlight this systematic review that Morgan and colleagues also published, and it really highlights the best evidence for children 0 to 2 that are high risk for cerebral palsy or have been diagnosed with cerebral palsy. And then one of the newest publications that came out from McNamara and all in the publication from 2023, this past year, really highlights interventions specifically for motor disorders in high-risk infants. So you can see here, they've categorized them into 3 different categories. And the second category, or the one in the middle that I've highlighted in red, has to do with an infant that would benefit from motor intervention that has a history of differences or damage to the motor system, but it's not progressive. And that would be an example of an individual that has been diagnosed with cerebral palsy. You can also see under there are identified major motor approaches to how to deliver therapy interventions for these children that have been beneficial. So motor learning, task-specific training, including high-intensity training, an environment that is enriched, and also accommodation, so we can promote independence, so using assistive technology or adaptive equipment. You know, this group loves the red light, green light, and yellow. So if you look at any of their systematic reviews, it's very helpful, and you can draw your eyes really quickly to what is evidence-based. So red is not evidence-based, and they do not recommend it. The yellow is that it's a conditional recommendation. And yellow above the dotted line indicates that you should probably do it. The yellow below the dotted line is you probably shouldn't do it. So the risks outweigh the benefit at this time, related to what the current research is showing. And then the green is strongly doing it. So you can see here, dating back to, you know, the beginning and babies ending up in the NICU stay, it really shows that the best level of evidence is promoting developmental care in the ICU for all babies. So across those three populations that I showed on the previous slide, but specifically our population, which falls into population 2, you can see this box is a little bigger than just the cerebral palsy, but their category, but I wanted to make sure we got it all. The two main things that are really strong related to evidence right now are environments that are enrichment, that promote enrichment, as well as a standing program as the child gets 12 to 24 months. But you can see there's still a lot to be done to understand what the best level of evidence is for children diagnosed with CP less than 2 years of age. So this is a, you know, vignette that we just really want to highlight. And you guys have maybe read this, but Zach, you want me to keep going? I'm good.
Yeah, or I can take over now if you want.
You can jump. All right. Yeah, I'll let you do it.
Sure. So yeah, like Lisa was saying, this is a really interesting article written by two parents in Canada that had some twins born at 25 weeks. One of them unfortunately passed away early in their NICU stay, and the other baby had a pretty challenging NICU course. But they got all the way to the finish line and to discharge, and they had an MRI that was done. And like is frequently the case in the NICU, the parents were sat down in a conference room and were given a lot of vague information about possible risks, but no specifics, very little in the way of, this idea of accuracy and precision that we've been talking about. It was just a list of words of possible risks, or maybe there's no risk at all. So both of these parents, very understandably, spent a lot of years very anxious about what their child's outcome was going to be. There was a huge amount of uncertainty and anxiety. And as it turns out, this is actually a picture of this child from the article, both in the NICU and then as a 4-year-old. She did not have cerebral palsy, even though that was something that the doctors warned the parents about, and has a little bit of a mild visual defect. But it really is instructive for us and informative for providers of the importance of providing accurate, helpful information for parents rather than just provoking anxiety without any help. So that's part of what this project is designed to do, to use this new early detection approach that's increasingly common in the NICU and the post-NICU clinic setting, and use it to provide useful information for families and providers, and get early interventions. So there's this idea that I've come up with. This is something new that I've only recently come up with, but I think it's sort of reflective of where we're going. And I call it the primer model. And it's meant to highlight all the different components that really optimize the best outcome for at-risk children. And it starts all the way with prediction and prevention. Can we predict which infants are at the highest risk for neurodevelopmental delay or disorders? What can we do to prevent it early on? If we can't prevent it entirely, what interventions can we make to reduce the risk of adverse outcomes or mitigate them even when they have occurred. And then in the longer term setting, early rehabilitation. And so this is really a comprehensive approach. It starts all the way with the obstetricians and the maternal fetal medicine doctors before the baby is born, and goes all the way through physical medicine and rehabilitation doctors and neurologists when children are older. And there's all sorts of steps we can take along the way, but we need to figure out which are the correct steps and the correct timing for each one of those to optimize this outcome. So as we've said a number of times now, the earlier we can detect cerebral palsy, the earlier we can intervene. But early detection is also very different than late detection. We're still talking about the same diagnosis. It's not a different diagnosis early than late, but it comes at a very different time period. When a baby is still in the NICU, there's a lot of stuff that is directly in front of the parents, the day-to-day things that they're dealing with, challenges with breathing or desaturation episodes, with feeding or other common struggles that we see in the NICU. And then this is a really big news for the family that is so much longer term than what they're dealing with on the day-to-day basis. That's very different than when someone is 2 or 3 years old, when their child is 2 or 3 years old, and they've had time to see the progression of their child. And I think many parents go to those appointments already having an idea of what they're going to hear that day. That's not necessarily the case in the NICU. So that requires a very different communication strategy. And this is something that we are hoping will be one of the potential benefits and areas that we're able to work with in this study, understanding how this communication happens. So who's in charge of that communication? How is certainty and uncertainty communicated with the family? This is something I often talk about with parents of patients that I talk to. It's not good enough to say someone is at risk for something or not at risk. Giving some level of how certain you are about that, it really helps to temper the amount of anxiety and concern families have. And then really important is who arranges that intervention. We know that early detection is important for early intervention, but how do we actually make that happen? Some folks live near big academic referral centers that have high-risk infant follow-up programs like the ones that Lisa was talking about earlier, but not everybody does. Many babies at these centers are transported from very far distances to get to the NICU for the care that they need there. But once they're done with their time in the hospital, who follows up? What is available, particularly in smaller communities that may lack these settings? And if they're not able to get them locally, how do they get to these bigger centers? So how does this interdigitate with what Paul was talking about at the beginning? So the CP Research Network was established in a different era, back when diagnosis occurred at 2 to 3 years. And the structure of the database and the data collection model really reflects that. It matches how CP care was provided at the time that it was started. But with these changes in early detection, there's this new gap that's developed where we don't understand as much about how this diagnosis is made, what risk factors may change the timing of this diagnosis, outcomes, and potential opportunities for research and clinical trials for these patients that are not currently understood because of this gap. But addressing this gap really meets both the CP Research Network goals as well as the Cerebral Palsy Foundation to optimize lifelong health. So this is not just early, it's not just late, it's the entire time, as well as that of their families. And it also meets that objective, that mission statement to be a premier registry for planning and conducting CP research in the neonate as well. Identifying these babies and getting them into registries where researchers are able to contact the families about eligibility for studies is just another potential benefit. So how would we do this? This involves an expansion of the network as it currently is, and it's going to require addition of a lot of other factors to the data collection model. Many of these things are what Lisa has already talked about, all these different tools that we use for early diagnosis. That's very clear that those need to be in there. But clinical vectors are also important too. one of the challenges that many predictive models that have been used by lots of different researchers in the NICU setting is that they often are very siloed. They're single domain, they're imaging only, or they're neurologic exam only, or they're clinical factors only. And that's changing. And the proposed expansion we have recognizes that these multi-domain factors from the entire hospital stay, covering all the different parts of what makes a person, it will really help to provide a greater level of explanation and a more accurate prediction in the long run. So it's important that we capture those factors too. Now, this means that we're going to wind up with a really long list of possible variables, and that's going to require some time and effort to sort through to figure out which ones are the most important ones. There are no standards. This is not a place where we can look up in a review paper or a textbook to figure out which are the variables that will be the most important. So it's going to require some expert opinion. So we've put together a panel of both medical and non-medical stakeholders that will vote on these. We'll come up with a list, and we'll start pruning down the list to the factors that we think are the most important. And then we'll take out the low performing ones, and we'll keep voting until we finally wind up with a list where at least 75% of the people on the panel agree that it should remain in. This is called the Delphi method. So the study is called the MedCP study, the Multi-Center Early Detection of CP study. And the initial start of it is just a pilot project. It's going to be 3 or 4 sites to develop and validate these variables and these new data collection instruments to try to work out the bugs, essentially, before it's expanded to a broader scale. So the first aim, like I've already mentioned, is to use that Delphi model to come up to a consensus of which are the target elements we want to include. Step 2, as is always the case with any sort of database, it's really important to make sure we're capturing the highest quality data, that we're not missing things, that we're not misinterpreting things. And there's several different ways that data will flow into the database. One's a more automated approach, one's a little bit more manual, and we want to compare them to make sure that we're getting equal, very high quality data in both cases. And then the third aim is to demonstrate that this is effective, that we actually are capturing infants with an earlier age of diagnosis of cerebral palsy. Paul showed that histogram earlier of the age of participants in the network, and it is skewed much older. There are very, very few babies, or very few babies in there, those that are under a year. So the goal is to see that distribution of ages change. And then there's an exploratory analysis. Are there differences in babies that we diagnose early versus late? I think this has already been suggested that babies that have GMFCS scale 1 or 2 perhaps have a later diagnosis than those that are 3 or 4. That might be one factor, but are there other clinical characteristics or demographic factors? All of these things are important to help us identify the most at-risk infants and get those resources to where they're going to be the most valuable. So data fidelity is crucial, of course. We're planning to completely examine all of the entries when we hit 50 enrollments to make sure that things are matching the source records, that the system is functioning the way that it's supposed to do. And then we're going to follow up. We use that Delphi model to pick the original variables to go in, and we're going to go back at 12 months and then again at 24 months to look at how the variables we picked are doing. And there might be some that we thought were going to be really, really good, and they aren't. So if they are missing a lot, or if there's a lot of errors in those fields, then we probably don't need them. So they can be removed again, same with that same 75% threshold. And I already mentioned the exploratory analysis. Lisa mentioned earlier that we've submitted a funding application to this, to the Cerebral Palsy Alliance Research Foundation. And if we aren't funded there are other avenues that we definitely are going to pursue to bring this project to fruition. So just to summarize everything that we've talked about today, the standardized screening tools that we have really have dramatically changed the age at CP diagnosis. And this is happening all across the US and the Americas and around the world. this early diagnosis is important because it allows us to get to those early interventions for the babies and the children that need it most. But research and infrastructure hasn't caught up with that yet. So this whole project, this whole plan is really to expand the CP research network into those early ages so that we can make that difference. And it's a huge set of potential implications for research, greater understanding of mechanisms, and then connecting these patients with potential clinical trials to change their course. And with that, I think we're happy to take questions.
Great. Thanks so much to both of you for the effort you put into defining this and pursuing this grant opportunity and this explanation. Zach, if you don't mind stopping sharing slides, that'd be great, just so people have. So let's open it up to questions. People have questions about what they're learning about in this, either about the early detection process or the study that's proposed or the benefits that would come from it. I'm going to take a moment and just get a sense. I see a lot of names here that I know, but I'm going to launch a poll and that'll give us a sense. I think we have a number of clinicians and a number of people that have followed the network for a while, but let's just take a moment and you should be seeing a poll on your screen now. And if you could fill that in, that will help us kind of understand the angle that people are coming at things from here. Working our way through. I've got results for 11 of 19.
And Amber has her hand raised.
Yeah. Let's just finish the poll. I'll review who's here for a second, and then I'll give Amber the floor to ask her question. See if we freeze out here at 14 out of 19. Give it one more moment. Okay, I don't know if it shares the results when I hit end, so at the risk that it doesn't, I'm just going to say that it looks like we've got of the 14 respondents, we have 5 are adults, 1 is a caregiver of a person with CP, 5 are adults with CP, 5 clinician researchers, 1 clinician, and 2 pure researchers. About 5 of the people said this is their first webinar, and 10 are MyCP members, 4 are not. Clinicians can be members as well. They just don't get surveyed. And then if you're a member, which services have you taken advantage of? And it's a combination of surveys. The forum recommendations are the main ones. Okay, so I'm going to end the poll. I'm going to I can share the results, which I didn't realize I could do. So I need to know that for future, but there are the results that we just saw. And just seeing this one last thing here on the forum, want to let everybody know we changed. If you've noticed that you haven't been getting mail from the forum, it's because we added a waiver, a release from liability, because we realized people could be taking some of what was being stated as medical advice. So if you haven't been receiving mail, if you go back to the forum to log in, you're going to get presented with that, and you click a button and acknowledge that you've read the release, and you'll go back to getting mail from the forum because the forums had a little reduced volume as a function of that. All right, Amber, you're up.
Yeah, I have 2 questions. First question is, are you including trauma-informed care in your education and early intervention education? Because I think that should be included as well. For medical, for medical staff, that it, because I know not all facilities are trauma informed. So, I mean, just a suggestion, I guess. I'm just wondering if that was considered at this point. And then, do you want me to state both questions before you answer them, or do you want to answer one at a time?
I guess we could do
yeah.
one at a time. Go ahead, Lisa.
I was just going to say, I think, recognizing the need for all NICUs and individuals that are delivering the diagnosis to have that type of training is very important. So I acknowledge that. I'm not exactly sure the state of that, and but that is definitely something I think to consider and needs to be looked at in the future.
Yeah, I just know that not all facilities are, and that some of the facilities that I've worked in have been and others have not been. So that was just something that I assume some healthcare professionals are, and then some facilities are and some are not. So just some feedback, regarding that. And then my other question is, I find it interesting that NDT is not recommended when they tried to become evidence-based. I don't know if you realize they've changed their curriculum, and I'm an OT, so I can tell you that and they have a book. I don't know if you've seen their textbook. So I'm no criticism one way or another. I'm just interested into why, since they've tried so hard to prove evidence-based that NDT does work. And I can tell you, because I have cerebral palsy as well, I can tell you that I think it's really it's like everything else, it's an art and a science. And I've had NDT done as an adult, not as a child. And it varies very much based on the practitioner, is what I can tell you. I had one therapist who was absolutely phenomenal, and she was trained years ago before they did all this evidence-based stuff. And I had amazing results. And then I've been treated by several other NDT therapists of varying years, and totally different. So I just want to hear the evidence of why that was like an absolute no, because that just intrigues me.
I can't speak to why it's an absolute no, but the researchers that did that, the way that they rated the evidence. But I think you have a very good point related to the interventions. We definitely want to capture the interventions that individuals are receiving, so we can track those kind of over time and really look at outcomes on a broader scale. We know with studies related to individuals with cerebral palsy, our ends are really small. So including this in the registry and tracking interventions that start in the newborn period throughout the lifespan really can help build the different levels of evidence and help us really differentiate between what is beneficial, what is okay, and what could cause harm. So thank you for that point.
Yeah, and just to add on to that, this is very much out of my scope as a neonatologist, but I think one of the other factors that goes into a lot of these is what we talked about with the precision and accuracy. Another component is variability as well. I think there are many interventions for patients of all ages that can be very beneficial, but if they're hard to perform or they're difficult to do on a consistent basis, when these systematic reviews are done, they're done, at an epidemiologic level, a really high level. So if on average for most patients it's not beneficial, even if it's very beneficial for some, I think that drives some of that grading or judgment of those particular methods or techniques.
Thank you.
It's a great point. And to add on to what Dr. Letzkus said, one of the reasons why we started this study is we had one of the leading early intervention researchers come to us and say, can you help us recruit? And we're like, we're not getting kids into the registry because the registry is a super powerful recruitment tool, but we're not getting them in until they're like on average 2 years of age. So it's so if we're going to measure the outcome of these interventions and talk about what which there is good evidence for, we need to be getting them in earlier. Dr. Novacek, you are up.
Hey, Lisa and Zach, thanks so much for your presentations tonight. It was really excellent. I really enjoyed it. I appreciate your leadership also in the CPRN. Question about maybe mainly for Zach, but both of you could answer, about the Delphi study that you're planning. Delphis, of course, are utilized when there's perhaps variance of a professional opinion. Can you expound a little bit on what areas you think are most debatable?
So in terms of those early detection tools that Lisa talked about, I don't think those are especially debatable. I think all of those are going to wind up in the final database. The place that there's going to be the most challenge, I think, is going to be the clinical factors. There are some that I think, again, will be non-controversial. Things like gestational age or birth weight are always very strong predictors and risk factors, but medication exposures would be, one potential one. Different types of sedating agents are it's still very unclear the potential risks or benefits of those. That would be one area where there might be some disagreement. Growth and nutrition during the NICU period. Things like breast milk use, other comorbidities, necrotizing enterocolitis, retinopathy of prematurity, and any of those could be very important or not. Though that's what we'll have to hash out, I think.
I think too, another piece that we definitely want to include is the social determinants of health.
Yeah.
And that's can be a very long list in itself. And so trying to narrow down what, we don't want a list that no one's going to be able to fill out, I guess, is the other thing. So kind of trying to weigh that. So.
Yeah, thanks. And that actually kind of led into a second question that I had, and some of the challenges of implementation and also acceptance, and gets to some of your issues, Zach, that you mentioned about, who wants to know, who doesn't want to know, and who's going to follow up. Any comments about the social determinants of health in that regard?
I think they're big ones, and it's something we've been looking at mostly in the NICU setting to begin with. They're powerful determinants after babies go home, but they influence it even before the baby is born. The idea of toxic stress of pregnancy in the setting of poverty and community violence, influences greatly the outcomes of neonates. Where babies are born is another big one too. Is a baby that's at risk for neurologic injury born in a setting where they don't have the skilled providers that they need and they have to be transported? There's a delay. Is that another factor? And it's really sort of consistent throughout the entire pre-hospital, in-hospital, and post-hospital setting. And there are some really nice tools. There's something called the Area Deprivation Index, which is a single value that was developed at University of Wisconsin. It's based on census block groups, so they're very small, compact geographical areas. And it's a single value that's normalized across the whole United States, that contains information about access to food, housing, crime, health insurance, access to healthcare in general. And it's a nice single proxy value. And that's something like that may really bubble up to the top of our list for social determinants, because it's a single value we can calculate based on a patient's address. And without having to manually look up, 4 or 5 or 6 different values that would tell the same story.
All right, thanks, David. Deneluk, you're up. You're also muted.
That's better. Okay. Technology is great when it works. I was born in 1963. Fortunately, I was born in the city of Vancouver. I had access to a very good rehab center. The thing is, I was born 3 months premature, but, and you have to remember, this is the 60s. I was not diagnosed until around the age of 2.
Mm-hmm.
My question is, specifically in regards to what is your experience or results have been with, let's say, preemie babies, 3 months to 1 month preemie? Have you noticed any challenges, any new information or results because the baby was born a preemie?
So I think, I don't want to speak for you, Zach, because you're in neonatology, but my colleagues in neonatology say, you know, the last frontier of neonatology is the brain. So they've made so many advances. We're saving babies now being born at like 22 weeks gestation. And they're doing amazing from a lot of perspectives. But the focus is still the brain and how we can promote the best outcome possible. So I can say the babies that are considered like late preterm are doing a lot better because of the interventions we have. And even like the way that providers are responding in a delivery room and keeping, I mean, this is something that we have, Zach and I haven't even talked about, but we were talking about the NICU clinical factors, but also maternal like factors, and also what happens in the delivery room related to, do they delay cord clamping or not? You know, that might be something we're interested in, or how, so I think there's been a lot of growth and a lot of interventions, especially around the actual birth. But I think there is going to be more, there's definitely a focus right now in, for early intervention in the NICU and what that looks like and how can we make that better.
Okay, thank you.
Yeah. Yeah. And just to add to Lisa's point, you know, something one of my mentors, Terry Ender, always talked about when I was in training was the fact that we don't, or at least didn't, routinely monitor the brain. In the NICU, babies are hooked up to all kinds of different machines and monitors and wires. But the brain is not one of them, at least not routinely. But it's incredibly important, and increasingly we have access to technology. You know, both the cost has come down, the technology itself has gotten better, and we're able to do neurocritical care, you know, neuroprotective care in a way that was not really as much of a focus in the past. Neonatology has always been a lung-driven field. People worry about the lungs and breathing, which is important. I certainly don't mean to minimize that in any way. But we've really figured that out. So it's time to move on to something else that is equally as important, if not more important. And the other thing that I think has also changed outside of technology, and I've seen this in the Lisa and I have both been doing this for 15 years. In the 15 years that I've been doing this, is the amount of intervention in the NICU itself. So all of these tools we're talking about, the GMA, the Hein, and so forth, are part of a standard of care in the NICU now. All of the babies in our NICU get those assessments, and they get them done before they go home. So that we really understand the risk of babies. It's, you know, they're not going home just as a 28-weeker. There are many different 28-weekers. So we have a much more stratified look at risk, so that we know who to provide these resources for. And if somebody falls, fails to follow up, or sort of falls between the cracks, we know who to go after, who's the most important to go after.
Great. at the risk of going a little bit over, Megan Munger's had her hand up for a bit. Dr. Munger, you're up.
Yeah. Yeah, I just wanted to add a comment and Zach this a little bit, but I'm wondering if the network were considering collecting something like zip code. You know, it's probably more reliably collected at a health system than even GMFCS level. But as Zach mentioned, we can use, there's a lot of information to be gleaned using that one little number, and that way we don't have to decide today what that actually is. But yeah, the ADI is on COI.
It turns out that zip code is not, PHI or PII. It's there, and we're actually turning on the collection of zip code.
You are awesome
in our future pushes. Yeah.
Good.
We'll have
That's
that.
great. Yeah, there's just so much that we can do. So that's great news.
Yeah.
With
And
that, go ahead, Zach.
And I was going to add the other thing, and I talked about the ADI. That's just one of the tools potentially, but that's a nice way to use that's at a census block group level, which is a very localized or geolocator for a patient, and that would be problematic sharing a whole address from a PHI perspective. But it's something that can be calculated first and then put in a registry. So the only thing that's going into the registry is the ADI itself. So there's not really a connection between the two of them. And
that is a possibility to add in the future as well. I want to be super conscious of the time. I want to thank you, Drs. Letzkus and Vesoulis, for your expertise. All of you that tuned in, especially our adults who just follow our work and are supportive of what we're doing. Greatly appreciate that. This will be recorded. This has been recorded and will be up for people that couldn't make it. But thank you very much for your time. Greatly appreciate it. Good night.
Thanks. Good night.
Thank you.